And welcome everybody. And just a reminder, again, these are our asks of you that this goes for 1 hour. We're asking that you stay muted, that you turn off. Please ask any questions in the chat bar and we will answer them at the end if we have time. And you can check out, we have one more panel and that's going to be on Wednesday, and it's going to be on working with providing support to frontline workers who are supporting people in the COVID pandemic. You can go ahead and make a donation to CSS. This presentation is free, but if you're interested in giving us a donation, you can go to our website, crisissupport.org. If you have any questions, you can email events@crisissupport.org for more info. You can follow us on Facebook, Twitter, and Instagram and keep in touch all year. And we want to thank our sponsors, Planter Day, Magoosh Online Test Preparation, and Rogers Behavioral Health. So today we're going to do a presentation and it's called Deepening the Connection. And it is a presentation on, oops, yes. You guys are really seeing the behind the scenes. And the purpose of this presentation today is talk about using collaborative relational practices in suicide prevention. And this is an 80s theme presentation. It's an 80s theme presentation because obviously everyone loves the 80s. But we also, the point of this presentation is to take more of an open and relaxed approach to talking about suicide. We hope this presentation is enjoyable. We hope that you feel comfortable participating and asking questions and feeling invited. And this is our hope in terms of reducing some of the stigma around talking about suicide. So our agenda today, we'll introduce ourselves. We'll talk about understanding our beliefs on suicide. We'll talk about maintaining the connection via telehealth and some techniques on client-centered assessment. Who we are. Who wants to start? Daniela?
I can start since I'm up there. Hi, everyone. My name is Daniela. I'm an LMFT and I'm the training coordinator at Crisis Support Services. I'm also a provider at Planned Parenthood. And so I have over 8 years of experience on the crisis line. And I'm bringing some experience of what it's like to be doing telehealth as a provider and also incorporating some skills that we've learned from working on crisis suicide prevention lines. Thank you.
And I'm Andrea. I'm an LCSW. I'm the clinical director at Crisis Support Services. I started working at Crisis Support in 2001, and I've been a crisis line counselor for off and on. I worked there for about 12 years as a paid person on the crisis line. And Tracy?
Yeah. Hi, everyone. I'm Tracy, and I am an MSW intern right now at the clinical program at CSS, and I have been in suicide prevention working on crisis lines and training and managing volunteers for about 6 years.
Welcome, everybody. Just a reminder again, if you can turn off your video when you join us, that way the people who are seeing the presentation can only see myself, Daniela, and Tracy. Okay. So we're talking today about suicide prevention, and effective suicide prevention starts with understanding yourselves. So we have an ethical responsibility to understand our own blind spots and biases around suicide. So if you don't mind, if you can reflect for a second on what were the cultural messages you received about suicide, and go ahead and drop them in the chat. We hold biases on suicide. They can turn into misconceptions. Some of the common misconceptions are that clients are only at risk of suicide if they meet criteria for a DSM diagnosis. And studies have shown that people can attempt and complete suicide without meeting criteria for a diagnosis. Another misconception is once a client is suicidal, they will always be suicidal. There's a belief that if somebody is at risk, then they are perpetually at risk and that they don't recover, which is also not found to be true. Another one is that most suicides happen without warning. And studies show that people who attempt and die by suicide often reach out to several providers and people in their lives and share these thoughts and feelings before they happen. As providers, sometimes the misconception we might have is that if my client is suicidal, we will know because they will tell me directly. So in this training, we're going to talk about being aware of some of those warning signs where a client might not say that they are planning on killing themselves, but are making it clear that they are hurting, that they're in pain, and that they're having some ideation. We also have a misconception that we might know that someone's suicidal because they fall into what we think is an identified risk group. Many people are aware that white middle-class men, middle-aged men are at risk of suicide, and we overlook other people or other groups because they might not seem to people that we think of having suicidal ideation or present as suicidal risk. And that might prevent us from screening everybody that comes into our office, which is a misconception. Another misconception is people might show certain behaviors that I will recognize. When we think about suicide, we might think that people are sad when they're suicidal, or that they present as unhappy, and we overlook that people can present as angry or irritable or numb. And that might be based on how our cultural biases around suicide and some of the things that we learned or some of the messages that we received about what a suicidal person looks like. So,
and Andrea, just to interrupt for a moment, there's a lot of great examples of cultural messages on suicide in the chat. Do you want to read them out loud or have me read them out loud?
Do you want to?
Yeah, sure. So I've got that it's taboo. We don't talk about it. Another is that you will go to hell if you kill yourself, or that it's illegal and you will go to jail. Suicide is selfish. It's a selfish thing to do. A lot are saying that it's selfish, or that was the message that they received. Suicide has a negative stigma attached to it. It's only for crazy people, that Black people don't do it. A mother called me at 2 a.m. 5 years ago and said, I would kill myself, come and get my 4 children. And Luisa's saying it's taboo, don't talk about it. There's a lot of stigma and misunderstanding that you have the choice to get happy or to be happy and just get over it. Also a few last ones, that it's a cop-out or that it means you're weak.
Right. And I also saw some misconceptions that it's only certain racial groups that attempt or complete suicide, and it's only for white people, or you're less at risk if you're Asian. And thank you for naming all of these. These are really strong biases. Sometimes we might have a chance to like reflect on them and think about if they're true or not. And sometimes they're just one of those biases that we don't really realize that we have until we take some time and reflect on it, or someone shows us that we're holding these biases.
Right. And I'm going to interrupt one last time. And Victor, if you're able to hear this, are you able to put yourself on mute? We lost our ability to mute all, so that would be great.
So these stigmas that we hold as a society, right, are going to influence us as clinicians, whether we like it or not. And so when we have these stigmas, it can bring up some anxiety about screening for suicide. One of the things that I think can help manage some of that anxiety as a clinician is if we're just really clear on what are our legal and ethical guidelines. So for legal ethical considerations with suicidal clients, this came from an article by Kampft, easily found on the internet if you want to go back and find the original documents. But as a clinician, our legal and ethical responsibility is to provide a reasonable standard of care for a client. So it doesn't mean that we're going to jump in there and solve it or fix them, or that we're liable if our client commits suicide. What we're required to do is do the basics and what's reasonable. And this involves doing an assessment and documenting your sessions with your clients. And there's a multitude of different clinical assessments that we can use. We'll drop some in the chat, and Tracy will go over how to do these assessments later. But just so you guys know, starting off, if you are doing an assessment and you're documenting that you're doing the assessment and you're documenting risk, then you're doing what is considered to be the legal and ethical guidelines. You're following them. And therapists are not expected to see into the future, and we're not held responsible for your client's actions as long as we can demonstrate that we made an effort to assess for risk. So that's the basics. Some important things to remember. A reasonable assessment is assessing for risk on the intake and documenting any risk present on the intake and on the subsequent progress notes. So I'm sure you guys all know this on the licensing test. But if a client presents with risk, you document that risk on every note until the risk is no longer present. If they present with any suicide risk, which could be minimal, can be ideation, you need to complete a thorough screening. If they have risk but do not meet the criteria for hospitalization, then you need to complete a clear and detailed safety plan. And we can go ahead and drop a link to what a template could look like in the chat, but they're all available online. And again, any risk is documented in each progress note for as long as the risk is present, and the treatment goal needs to address the risk. Anytime a client presents with a new risk, you would go ahead and update their treatment plan if you have an active one. So how do we do this via telehealth?
Great, so I'm going to talk a little bit about this piece. There are definite differences. My guess is that most folks here have experience of working with people in person and now working with folks over telehealth. So to talk about the pros of telehealth, because I think we do sometimes focus on how unfortunate it is in some ways that we're stuck in this way. But it is important to address some of the benefits that can come from this way of working with people. So one of the pros is it does reduce barriers to access. For folks with mobility issues, it's more accessible. Clients don't have to transport themselves as far or at all. And then in terms of money and saving money off of transportation, that's another big piece. We can also see a specific kind of window into a client's life with telehealth that isn't always available when they come to our space. So we see their interior home, we can see what's causing certain interruptions, we see pets and how they engage in their home environment, which can be really helpful information to have. There are some clients that have increased. Nope. We lost the slides there. Andrea, are you still here? You may have lost the Andrea. Let me pull up that slide so I can keep talking. Thanks for your patience, everyone.
Yeah, I can actually present that if you'd like.
Perfect. Yeah, go for it. This is one of the cons of telehealth, in case anyone was wondering, that we are relying on internet function and it is not always wonderful. We are also relying on these internet platforms, which are not reliable 100% of the time. So it does result in some of these moments and there can be a breach in rapport and it can be awkward. I know I just had an intake session with a new client last week and we spent the first 20-25 minutes trying to get our technology aligned. So
yeah, with that being said, right, ruptures can always be repaired. Just so
yeah.
I'm with working collaboratively is that the host has disabled sharing screens. So we won't have visuals until Andrea joins us again, but maybe we might be able to just relay the information using this method.
Yeah, let me just pull up the slides. One sec.
Hello. Live. So today I'm doing a live on suicide awareness and prevention books. September is
one sec.
suicide.
And Robin, if you can hear us, if you could please set yourself to mute.
I have.
Hey everybody, sorry, my laptop just quit. This is like
No
more.
worries. We got you.
Thanks, guys. Okay. Oops, now I can't see anything.
So I'll just keep talking. We were on the slide of the pros and cons, and one of the other pros that can be considered is how flexible we can be with someone who is in a suicidal crisis. And this sentiment carries over from our crisis line work. Oftentimes, we will be on the phone with someone. They're trying to figure out how to get to the hospital if that's something that they choose for themselves, and we can stay with them. Oh. And Louisa, if you could mute yourself, that would be great. Thank you so much. so yeah, it does give us that kind of flexibility where we, you know, if we're with someone, it's not appropriate for them to get in our car and go to the hospital. If we're on the phone with them, we can be in that space en route if we're helping them get services in that way. Some of the cons, as we've now demonstrated live, are that there can be these breaches, and it requires a baseline tech savvy for some folks. But like Daniela was saying, any breach has a really like fertile opportunity for repair after. Another thing that is limited is our assessment of folks. So there's smell, there's gait, there's postural nuances, dress, the feel of just being in a shared space with people. We're having a different experience. And that's not to say that we can't really hone our other senses, but it is a different experience. And for some clients, there's also the negative impact on the rapport. There's a felt sense of distance from having us on the other side of a phone, on the other side of a computer. But I will say that very much goes both ways. I think that there is increased intimacy for a lot of individuals while they have that kind of space. There can be a freedom in having the space. There can be a freedom of them being in their own space that can actually lead to more comfort for a lot of folks. And the last thing I'll mention on here is that it limits some of the, it doesn't limit, but it changes the way that some of the shared tasks play out, like doing the assessment at the beginning, intake, and safety plans, things like that. It's paperwork, and it's things, these are things that we can do in conversations with people, but it's just a different thing to do it over the phone. And I have found that there can be more room for getting distracted in those things when we're over the phone. And then of course, like alternative modalities, art and movement, they can still very much happen on telehealth, but it's a different experience. All right, Andrea, feel free. Great, so another thing I wanted to mention on the pros cons, it was best practice previously to not actually work with suicidal clients over telehealth, to have those clients see therapists in person. And that is changing because so few people are seeing folks in person. And so we are really needing to double down on being on top of things with our assessment. We need to be thorough with the intake and
watching this
in the revisiting of someone's risk throughout the time that we're working with them. So in doing this, we want to begin on day one. We want to talk about suicide on day one. Like this is not something that's mysterious over there in the corner. Whatever intake we're doing with someone needs to happen right away. And so in doing that, we are having that on the table. We're getting an understanding of the context around someone's suicidality, if it's currently something that's up for them, if it's something that's been up in the past. Daniela's going to talk more about how to do this over telehealth in a way that serves the rapport of the therapeutic relationship. And that starts right away. We hear on the crisis line a lot that folks don't tell their therapists about their suicidality. They don't often feel that it's a safe space for them to enter into that conversation. And so they'll call us on the crisis line and tell us all about it. And what I've heard over the years is that it's often they feel blamed, they feel shamed, or they feel like the therapist is going to jump really fast to more extreme measures, taking that person to the hospital, or not taking, but getting that person to the hospital, calling the police for a welfare check, things like that. And so it doesn't feel like a safe space to talk about suicide. And so in that sense, normalizing it from the get-go is really important. And we're all doing confidentiality paperwork with people right off the bat. And so that really gives us a chance to say, hey, this is one of the handful of incidences in which I'm going to have to breach confidentiality if I believe that you are harm to yourself and others. And there's a lot of room to open up that conversation into also saying, if you tell me you're suicidal, that doesn't mean I'm calling for a welfare check. There's, in the conversation about suicide, calling for a welfare check or getting someone to the hospital is such a tiny portion of what it is to have conversation about suicide in the room. And so just really making that apparent to the client. And so another part of that intake, and Andrea will drop this in the chat, but we can do, we want to, if that person is expressing risk, we want to take some time to do a safety plan with them. Andrea's going to drop that in the chat. We also have, there's different rating scales, but there are ways to do more thorough suicide assessment with the support of paperwork. And so there's something called the CSSRS, the Columbia Suicide Severity Rating Scale. And it can be helpful to lean into something like that because it's going to give you a lot more nuanced questions about getting into someone's suicidality and how that actually manifests in their life. Another quick couple points to touch on are familiarizing yourself with resources local to the client. And this ideally happens in a transparent way with the client. Of course, we might familiarize ourselves first, but then we want to be having that conversation with the client about what are their local resources. And so telehealth means that we might be working with people outside of our areas, and that really just heightens the need for us to recognize that if that person is in crisis, we want them and us to be aware of who they can call in. So crisis drop-in centers, Alameda County, it's like Amber House, hospitals, mobile crisis, CAT teams or new teams being deployed by 911 with a paramedic and a licensed clinician. And then also the crisis line. And you can always call the crisis line together, the crisis line local to that client. And that person will always be able to, almost always be able to walk you through what to do. It's a really great resource, you know, if you find yourself at a moment with a client where you just need a little more support. And then the last thing is with COVID, be ready for bigger than usual gaps in some of the resources. So hospitals are also running, Amber House is running, mobile crisis teams, all these things are running, but they are often running at more limited capacity than usual right now.
Okay, I'm gonna go ahead and figure out how to mute all. So our presenters are gonna unmute themselves.
Mm-hmm.
All right. So thank you, Tracy, for introducing us to how we can start to lay the footwork to being collaborative from the get-go around talking about suicide. And now we're going to talk about how you can use a collaborative approach to continue the conversation around suicide or continue to assess around suicide in a way that helps create a safe environment, still provides reflection and empathy to the client, and also do your diligence around a safety assessment. Something we do want to mention, if we haven't mentioned already, is we're not walking you through how to do a thorough suicide assessment. We, you know, this is more so when you do see the signs or breadcrumbs or indications that someone may be alluding to suicide or thoughts or feelings that are down or depressed, and you wanna lean in more to that, how to start having that conversation. Because right, you've created this rapport with the client, you are ready to talk to them, but what does that look like? And so one of the things we use is the CAMS approach, which is the Collaborative Assessment and Management of Suicidality. And this really is an approach that helps us know that we need to, the importance of truly listening to the story of the client in an empathetic and non-judgmental way. We want to avoid shame and blame. We don't want to argue or distract or try to cheer up, but really, like, how do we be there? And we be there in a collaborative way. So at the heart of this orientation is the core tenet that clinicians must really truly listen to the person's story. That doesn't stop because someone's giving this indication that we need to assess further. We just continue doing what we're doing and then lead in that assessment. And this is also by David Jobs, the Collaborative Assessment and Management of Suicidality. All right, next slide, please. And so kind of helpful guidelines around how to talk about suicide is we want to avoid trying to jump straight to what makes you feel better. Coping skills and self-soothing strategies are very helpful. They're great. We're all about protective factors. However, we don't want to jump straight to solving that problem just yet because we run the risk of missing hearing their story, really deepening that connection, or we might not conduct a thorough suicide assessment if we just jump to problem solving. So in order for people to feel connection, people like to feel heard. And so we really want to start opening that space up. And one of the ways we can start to open that space and have that collaborative conversation is working with ambivalence. And what I mean by this is we want to be willing to lean into the emotional or suicidal content. We want to lean respectfully from a place of concern and care and a sense of respectful curiosity. Suicide prevention isn't just exploring the reasons why someone wants to live, but also includes exploring the reasons they might want to die. You can both create a space for this exploration while reflecting the life-affirming parts of your client. So if you think about it, if they're not naming it, if you're not naming it, even though you're having a sense something might be going on, we can't really provide support around something that's not being named. And it also shows that, hey, as a clinician, I'm willing to talk about this. This is a space we can talk about this, and let's kind of explore all of that. And then we want to clarify risk and imminence. So along with, the suicide assessment, you are continuously doing every session, and especially the very thorough assessment you're doing when you start seeing indicators that someone might be having suicidal thoughts or feelings. Conducting a really thorough assessment can help you and your client consider how to maybe best use that time or how you want to shape that session. So depending on the level of safety that you establish, you might get to spend more time exploring the client's story, their reasons for wanting to live, wanting to die. You can work collaboratively towards means and safety planning, because maybe that's really what's important. Or you might consider utilizing interventions or other resources, starting from the least invasive, right? So if you have someone where they're expressing some suicidal desire or content, and then you establish safety, you have a sense of, how safe they're going to be, and you have time to really get into what's bringing up those feelings. Whereas if you have a client and you're getting a sense, wow, this person really doesn't sound like they're going to be safe, maybe that time is going to be spent, what do we need to do to keep you safe today? So that way you can kind of weave that. And then something also to mention is, as we've all had experience on the crisis line here, being on the crisis line 8 years, I've had conversations about suicide a lot. And being a therapist, it can feel very different having them in telehealth because the rapport can be different. This is someone you've been working with. So I kind of want to normalize that it's not always easy to have these conversations. And, it's kind of like that saying, the only way out is through. We got to start having to talk about the difficult stuff before we can get to the other stuff. So next slide, please. So one of the ways we can have this collaborative conversation is something we use at CSS called the yo-yo technique. So this is really a two-pronged technique where we're finding a balance between maintaining connection while also conducting a thorough risk assessment. And so we want to both provide that empathy and reflection throughout that assessment while gathering information. That might look like hearing the client describe how they're feeling, pausing and stopping and reflecting and responding to that, and then following in with a question. Because what can often happen is if we're not comfortable talking about suicide, if we hadn't laid that groundwork in the beginning with the intake and throughout sessions, and you find yourself in a place where, oh no, what's going on? I haven't done a suicide assessment in a while, or oh, I'm really concerned about my client. Rapport can be kind of shaky or broken if we start going into just this robotic assessment. So we kind of want to weave that in a way where we're not just trying to check off boxes. We're showing care and the reasoning behind why we care or the current concerns we're hearing or seeing. So using this technique really allows us to keep the emphasis on the person's experience and stories while continuing to do our due diligence around assessing risk. And the reason it's important to have both of these things is if we only have empathy alone, we might be missing really important assessment questions, right? We might not be getting as thorough of an assessment, risk assessment. And also for some clients, having empathy alone might feel disingenuous when someone's in an active suicidal crisis because they're maybe reaching out for help or wanting more. And what can be invasive to one person might be what another person wants. And so we want to really keep an eye on that. And then also, if we're nothing but directive, it can feel like that getting that information is unearned, or it can also feel disingenuous in a way. It can seem robotic. It can give this indication that it might not be a safe space. we might also run the risk of the client might tell us only what they think they want us, that we want to hear from them. If we're just asking a series of questions. And so like Tracy said, even though there are things that we might miss from getting that felt experience of being in the room, there's also so many other ways to convey empathy and concern without that, such as, you know, nonverbal cues, really picking up on what's happening over the phone, silence. It's almost as if, you know, when one sense goes out, another sense is heightened. We want you to practice that also over the phone. Great. So we can talk a little bit about kind of what this looks like in real life. So one of the things that is a limitation, but also a benefit, right, of teletherapy is that you can be there with the client in maybe spaces you might not be able to. So say you're with a client and you are in an office setting or healthcare setting or anything like that. Maybe the place you're in might have specific protocols on what to do if you're in the room together, right? If you have a patient, and this is where you know, I would check in with your supervisor to understand your roles and limitations and what you can and can't do. But for me, working in a healthcare setting, I know what we would usually do in person is not what we can always do in telehealth when I might be working from home. And so, you know, I've had experiences with a client that is suicidal and was in more imminent risk than usual, and trying to figure out how to have the conversation about suicide, but also what does it look like to help keep someone safe from the least invasive options. So for me, what that looked like was continuing to have that conversation, but also conduct a safety plan. Like, what does a safety plan look like? You know, do we want to walk someplace together in a way that's safe? Because also the reason why so much of this is in telehealth now is because of the risk of COVID and trying to stay safe. So how does safety planning and what the next level of care looks like when you're not near your client but want to help promote that safety? And so in one particular instance, I remember that when we got to a point where this person was wanting more help, and they were very collaborative, and we talked through all the different options, right? I conveyed concern, you know, I'm hearing that you're feeling this way, and even though you're telling me this, I'm also hearing this. Does that feel right for you? What are ways that you feel like might help keep you safe? But realizing that if we end the call, I'm not entirely sure if this person will continue to stay safe. And I communicated that to them, you know, hey, I'm worried, you know, that if we get off the call, that what's going to happen next. And you know, this sounds like it's been more intense than it has been recently. And you're telling me you're not sure if you feel like you're going to be safe. Like, what are our options? So we actually talk through, is there someone in the house? Are you alone? Can you talk to whoever else is there? Okay, no one's there. Is there someone that can come over? Also considering that everyone has their own, you know, safety precautions, someone they feel safe coming over. If not, are there other places that you can go to be around people if that is something that is safe? And then it eventually turned to, okay, like, can we call the mobile crisis unit? Like, would you like someone to come out and meet you or talk to you over the phone? And in this particular county that I was working in at the time, the mobile crisis unit was not going out. It was still over the phone, very much like I was over the phone with my patient. And so it turned into, okay, like, how can we get you prepared for if you don't feel like you're going to be safe? Maybe the next option is going into, there is no local crisis residential place in the client's area. So it was, what does it look like maybe going to the hospital, talking through the fears, the concerns, what they hope to get, what they're worried might happen, while not promising anything, of course. And then I had the opportunity to really stay on the phone with this person up until the moment non-emergency services arrived. And we handed over the telephone just to make sure that they made contact. And I was on the phone with my client, letting them know, you know, we can follow up after this. We can touch base if I don't hear from you, making a plan for when I can call them next. And in the meantime, looking up for other resources that might be available to her when she gets out of the hospital. So that's just one way that worked out while I was on telehealth. And I would have never been able to actually stay on the phone with that entire process, or in a sense, walk with the client somewhere else, because it might have been too overwhelming to be in this person's in her own home. So yeah, it's my kind of case example around that.
Thank you, Daniela. And so this is what we had to share with you guys. We would love to know if you guys have questions, thoughts, concerns, experiences that you've had. You can go ahead and unmute yourself if you just want to ask us, or you can drop them in the chat.
I do see Victor has a question in the chat. That would be a good one to voice. So if a client has chronic suicidal ideation, are we required to create a new treatment plan or contract?
No, I would only update the treatment plan if there seems to be an increase in the ideation. But if it's a chronic one, then I would just have that be noted on all the notes and all the plans.
Mm-hmm.
May I ask a question?
Yeah.
Thank you so much. Like I said, my name is Nariman Naween Khatak. I live in Modesto, California for 39 years. And I just I work in the clinic hospital as a certified medical assistant. And I remember 2:00 a.m. 5 years ago, a lady, I was helping her. She was a refugee from Afghanistan. She called me, and I know her story because her husband left her, you know, and she came with 4 children. I went to the airport, I picked her up because I was a translator at that time. So when she called me 2:00 in the morning and she said, I'm going to suicide, she always was talking, and I encouraged her not, you know, because you have children and your husband is not there. You're responsible for children, you know. When she called me 2:00 in the morning and I jumped from my bed with my pajama, I just went to Turlock from Modesto, a kind of 25 minutes driving. I asked her, you know, why you're doing that, you know, tell me. She said, because I'm done with the life. And the time was 24 years old and 4 children. The 2 children was, you know, twins, a boy and girl. I said, you know, Fariba, you're responsible for these children, you know. I mean, I didn't have much experience, you know. For my own experience, I was begging her, you know. The children, as soon as they saw me, because the mom was holding, you know, like a fryer pan with a full of oil, like a flame is coming on the top, you know. And I told her, you know, if you're gonna think, you know, you're gonna kill yourself, you're gonna be done. No, you're a mother, you know. And I just, like later on, you know, like now she's a hairdresser, you know, she bought a house, you know, she's a good life, she got married. And I asked her one day, what made you that you put down, you know, you don't want to do the suicide, and you came and hugged me, you cry with me. What? Till 6:00 in the morning, I was begging for her. She said, you know, the way you was so kind and nice and talking to me, and she told me, take the 4 children with you. I said, you know, because usually in the past I took her to crisis children in Modesto all the time. I was taking her with a car seat, you know. I said, honey, it's not gonna work like that. They're not gonna give me the children. The children will go to crisis center. From there, it's gonna be everybody adopting these children. I might gonna take only 1 because I have 3 children. But I told her my own story when my husband passed away 9 years ago. Right now it's 9 years ago, that time was. I told her, you know, I had a lot of struggling. I was working 3 jobs. And now look, I'm gonna tell you, you know, my children right now, 1 doctor, 1 engineer, 1 physical therapist, you know, all 3 of them. How proud mom I am to see my children. Why you're doing that? These 4 children, one day is gonna be somebody. And she told me, that's my little experience, sorry about, I'm talking too much, but I said, you know, because of my little experience, she said, you're so kind and nice, the way you talk, and that's why I want to just forget it. I'm not going to do that. So am I did it right? I'm asking you guys. I'm sorry, you guys, what I did, you know, I saved her life. And today she's a very proud mom. Like I said, you know, she's very happy. When she talked to any Afghan about me, she said, Nariman, she's the one saved my life. And make me so happy and proud. Thank you guys for listening.
Thank you so much for sharing that story. And I think that's a story that really highlights the importance of having the relationship. And she knew that you cared about her. And that's something that we want everyone to take away from today, is like staying in a relationship with somebody is so key, right? Because they hear us when they know that we care.
Yeah, oftentimes I in training let volunteers know, you know, you'd be surprised the kind of questions you can ask when you're conveying a lot of empathy and people feel listened and heard. And it's not in addition to be, ooh, I'm gathering information. It's because you're always gathering information because you care about the person, you're concerned about their safety. Something you had also brought up was this idea of, you know, you have kids, how can you do that? Because right, everybody has different ideas of what might keep people alive or what's the reason to keep living. And while there are protective factors, everyone's suicidal state is kind of like idiosyncratic. Like we don't, risk factors alone and protective factors alone don't predict who might go on to die by suicide. And so it's really the relationship you have with your client and how to keep that collaborative that can really help you with that. And sometimes when somebody is in such a deep suicidal state, sometimes it's hard to think of the protective factors or those life affirming factors. So it sounds like you really connected with her.
Yeah. I see some other questions, so let me just go ahead and oppose them. So how have we been handling hospitalizations with COVID fear and a fear of contact with others? That's come up on the crisis lines. I'm not sure if Daniela or Tracy, you want to speak to that?
Yeah, I can speak to that. Yeah, it's not great because for obvious reasons. And so people are very concerned about going to the hospital, many way more so than they would have been already. It's already something that can be a really complicated choice for someone. And so what is happening at most of the hospitals, to the best of my understanding, is that they are all employing very specific COVID procedures. Some are letting in less people to have more space and be able to have social distance and all those requirements met, but they are still functioning as usual. And so it's like so many things in the work we do on the crisis line, where we are working within systems that aren't ideal always, you know, and there's a lot of things that if we were to just build our imaginary world, we would create it different, but it's not that thing yet. And so how are we talking to someone who has a very, very legitimate fear? We are just acknowledging that fear is legitimate, and we are exploring with them what their needs are. Are they at risk? Are they not going to be able to stay alive? And we are centering risk in that conversation, but also, you know, in the example that was just shared, it's so beautiful that like we can center risk and we can also really take space to be in that relationship. So if when I'm on the phone with someone who has that kind of fear, we are having a conversation where all of those fears about hospitalization are brought into the conversation, and I'm sharing what I know, which is what I just shared with you about the precautions that the hospital is taking. And then it's really a collaborative approach to center that client safety while also making all the space in the world for them to talk about why they may want to go to the hospital and why they may not.
Mm-hmm. Yeah, and just to add with this, especially with the example that I had shared, like this wasn't like a 50-minute session, right? The 50-minute session goes until it ended to keep this person safe. And so we explored many different things. And I always see hospitalization as like last resort, right? Or like or involuntary, like, you know, it's very last resort having to call. And so I always determine, you know, if they're alone and I've made a thorough enough assessment and they're telling me they're not going to be safe, even though there is the real risk of, you know, coming in contact and all of that, you're also weighing that against someone's life, right? Like like they're telling you they might, you know, not want to live. And so it's really tough. And we explore, like, you know, we think that like this might be the option, given that you're telling me that you might not live if we don't come up with another option, and then this might be the option. Also, like Tracy, you shared your information of, you know, that about the, like your experience about the hospital, and so as you know, providers, clinicians, community members, you can check out your local resources, call ahead before you're in the position where your client's suicidal and find out, hey, so what is your protocol, or what is going on? Or if I wanted to send someone to the hospital, that way, if you have that knowledge, if that comes in play, you can share what you know with the client as well.
Mm-hmm. And I just also want to put a quick, I love what you just shared, Danielle, and I want to put a quick plug in for connecting your clients to our crisis line if they're open to it. Not everyone's going to want to connect in that way, but a lot of what we do with folks like Daniela and Andrea and I have been talking about is look for the least invasive intervention. And so many times we're talking about hospitalization with folks, but what we end up doing is maybe checking in with them every hour for the next 7 hours. And we make a plan on the hour for the next hour and we check in. Or maybe we make a plan to, they feel like they can stay safe for 4 hours and they're in the meantime gonna call their therapist and they're gonna go for a walk. So we do a lot of that kind of being there in whatever way works within our scope to support them through those more acute moments where maybe they are thinking of a hospital, but maybe there's also another way for them to stay safe in relationship.
Thank you. That was my question. I just wanted to say, because I was also thinking about voluntary hospitalization. So, because I have clients who also use that as their way in their safety plan. So, but it helps me understand it more. So thank you.
Thanks, Andrea.
I'm going to go ahead and stop sharing. It's nice to see you guys. So we have some more questions. One of them is, do we use apps like My3 app? I don't know. I don't actually use apps, but I know there's a lot that are available. I don't know, Danielle or Tracy, you've had experience using them?
I've heard great things about that app, but I haven't used it myself, so I can't speak to it.
I don't know. I don't use apps. And, you know, maybe if it's like an intake or as I get to know a client, I ask like what they're, you know, coping or self-soothing, if there's anything that exists or if they like. And then if I, you know, or maybe I might ask, would you be interested in something like this? And I might do that research. I mean, I'm sure I have like a list typed out somewhere, but I'm not an app person myself. So, sorry.
Because I'm not sharing my screen, I can now find those things that I was going to put in the chat. So that's the CSSRS. Again, it's really free and easy to access online. The other question that we had on here is, have we seen anyone's suicide bias impact their ability to do suicide assessment and safety planning? I don't have a story about a time that I've seen that. But I will say that as somebody who has done a lot of work in crisis intervention and suicide prevention and been a supervisor, I've noticed we sort of immediately will have a bias, and that's okay, right? Like most of my trainees will name fear and uncomfortability, discomfort, and worry just about saying the word suicide. I think, again, like the stigma we have in our society is so large, and it's so large, I don't think that we really have a perception of how it impacts us. But an example of this, and this is sharing my opinion, but I think an example of some of the ways in which that biases presents itself is that very few graduate training programs in mental health talk about suicide. Something like 13% of all graduate programs in social work, counseling, marriage and family therapists, psychologists address suicide prevention. Very few have like whole classes on it. So I think even the field as a whole has a bias against suicide, even though it is, as you all know, it's the 10th leading cause of death in the United States. So that's what I would say about that. I don't know if Danielle or Tracy, do you have any ideas?
It makes me think of like volunteers who are new to the crisis line, where we'll often see a hesitancy, exactly what you're saying, Andrea, about saying the word suicide, or when it's said, it's almost like lights out, big music, suddenly that word was said, and it's a stopgap in the conversation. And so I think something that we like to see on the crisis line is just getting this language moving through our bodies and through our system and in these conversations in a way that diffuses it from that like dun, 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 kind of experience. And so, being able to say things like, you want to die today. Let's talk about that. So I do see that hesitancy to go directly towards the language of suicide or death. Specifically, like, are you thinking of hurting yourself, which can be the natural inclination for folks sometimes in their assessment of suicide. They're asking someone, are you thinking of hurting yourself? And that means, so like, to hurt oneself is such a wide range of what that can mean. And so often someone can be having thoughts of hurting themselves, but it actually is very different from a suicidal thought. It is not linked to a suicidal thought. So I do see that bias factoring in. And I think getting comfortable saying suicide, talking about death in a normalizing way is really important.
Yeah, I'd like to add, since we did mention somewhere in the beginning of the presentation, we invited people to think of different assumptions, like maybe like cultural, like, different things depending on them. And sometimes I find a place to watch out for bias is when you're having that collaborative conversations about why someone might want to live and why someone might want to die. We're hearing their story, to check your own assumptions and bias in that moment, because maybe someone's reason to want to die, you might have a reaction to be like, that may not make sense. You want to stay kind of really empathetic, or the reason to live. Like, there might, like, suicide and death is viewed differently in different cultures. And so it's really important to get a sense of understanding kind of your client, what you're working with. And instead of, like, we're not arguing or changing people's minds or anything like that, but being like, okay, yeah, we hear that this is on the table, like other things are on the table. Let's talk about what's on the table. Tell me why this is meaningful or significant, or the impact for you. And so kind of, I think, checking your bias during that collaborative conversation too, so it continues to flow.
And this is, again, I'm sure obvious, but this is where consultation really comes in. If you're working with someone who's high risk, if I'm working with somebody who's high risk, I tell one of my colleagues, I have a consultation group, I have people that I check in with. As soon as there's somebody where I'm like, I'm a little worried, I tell somebody else, so I can get that sounding board. Because of course we're gonna have blind spots. And so if you are still developing your support or developing your colleague group, call us. That's what we're here for. If you have a client who is suicidal and you just want to check in and make sure you're not missing anything, you can call the crisis line. Or you can go ahead and reach out to me and we can do a consultation. That's what the crisis line is for.
I saw a question that had said, what do you do if I assumed like it's up further now, but when you're in session with a client and then it's running over, like, what do you do? I think one of the benefits that I've seen so far of telehealth is when I am transparent of, like, hey, I let someone know on the phone, like, I'm going to actually consult with my colleague or my supervisor, or usually it's my supervisor or our director, whoever, and we're going to work together to try to get you some help. Is that okay? Right? Like, I'm just like being transparent about what I'm doing in the process sometimes, to the extent you can, because then depending on your setting, right? Private practice might be different, but depending on your setting, like, you can have someone facilitate, maybe calling other clients or doing something else, rescheduling, things like that. So when I'm being collaborative, and even kind of to speak to your point, Andrea, of, if you consult, there's another question here about what about risk and what if you're concerned? Like, I remember as a trainee and an associate, I would say, I want to get extra support with this. I want to find more ways to support you. And I feel like you can get all the support you can get. I may consult with my supervisor just to get a sense of what else might be helpful. So we're like being transparent around, hey, I'm telling you, I'm going to consult, but that's just the way I lean. So.
Mm-hmm. Yeah, and I'm just going to voice Shelley's comment. When working with teens, it's important to first check their location and which caregiver is present for them before beginning sessions, so that we have a lay of the land. Yeah, and I also just wanted to share right above that, I put a link in the chat. It's a 25-minute role play of a high-risk call on the crisis line. So like we've been sharing, we're not going through what a suicide assessment looks in more detail. We're really trying to broaden the conversation for this hour presentation. But if you want to hear what that can look like as an example on the crisis line, there is a link to the SoundCloud.
Mm-hmm. Oh.
I'll go ahead and address Alice's question. Hi, Alice. So she says that one thing that seems important as you have somehow been able to do this work without being focused on your own fears and your own potential risks, such as the risk of being sued, There is so much emphasis on risk and training programs. I wonder how you talk to trainees about doing the best work possible without focusing on their own exposure to malpractice of their own risk. And I will say I have been doing this work for a very long time. And when I have a client who is suicidal, I get that, you know, like it still comes up in me. And I don't know if that's ever going to go away. So I just wanted to name that. And I do have, you know, all of these concerns about what's going to happen and what's the potential liability. It doesn't go away. So that is why I've done the research and looked into like really what is the legal and ethical responsibility of the clinician. And I really appreciate that Kempt in the article really lays it out clearly that we're not magicians, we don't save people. All we have to do is provide a reasonable level of care. And that's what I try to talk to all of my clinicians about. And again, I think reasonable level of care is having an open and collaborative conversation on suicide, and then doing something like that CSSRS, which is an evidence-based tool, writing it down, putting it in the client's chart. It comes down to documentation. But there's no sense, I think, from the larger systems that we're not going to lose a client to suicide. I have lost clients to suicide. That's a reality, right? This is a population that we work with. And that's helped me kind of understand really what is my scope. And we can only do so much, and it helps me to remind myself of that. We have about 2 minutes left. Any last questions? If people, again, are looking for a more thorough training on assessing for risk, then we do have a community ed program, and they will go out to agencies, schools, and they have a whole presentation they do on talking about suicide. So that's on our website. It's always available for you. And then I put in a link to the CAMS site. It's camscare.org, and that can be a really great resource if you're looking to learn about suicide prevention. I recommend the CAMS model for lots of reasons, one of which the guy who invented it is like obsessed with it, and I love that. And it's not coming from a specific modality, so it doesn't matter how you practice. It's a good platform and a good approach to use if you're a CBT, if you're a psychoanalysis, postmodern, whatever your approach is, and he walks you through pretty clearly how to assess and manage risk. So that's one thing we recommend. But again, if anything else comes up, feel free just to reach out to the crisis line.
Thank you everyone for being here.
Thank you, everybody.
Bye.